This is the second part of my presentation on the cancer risk related to X-ray imaging. The effect of low doses of X-rays on cancer has to be re-evaluated after the discovery of mammography-induced cancers, which was stimulated by the paradoxical absence of benefits from mammography screening. To demonstrate that mammography-induced cancers are the cause of the poor efficiency of mammography screening programs, I will show you evidence that in cancer-bearing women, mammography screening is decreasing breast cancer mortality by intercepting breast cancers at an earlier stage. Then I will summarize the epidemiological evidence that screening mammography has almost no effect on national breast cancer mortality, leading to the conclusion that to maintain a constant rate of mortality requires additional cancers which are always observed after screening implementation. Now we will see that in cancer-bearing women, mammography screening decreases breast cancer mortality by intercepting breast cancers at an earlier stage. Mammography detects cancers on the average more than 1 year before the clinical diagnosis. The probability for a cancer to give rise to metastasis is a function of the number of cancer cells and of time. This probability is a function of the area under the cancer growth curve. Detecting the cancer and removing it 1 year earlier should distinctly decrease the incidence of metastasis. In women engaged in screening, clinical cancers are interval cancers, whose incidence rate is only a fraction of the cancer incidence rate before screening. In women participating in biennial mammography screening, advanced clinical cancers, which are interval cancers, represent less than half of the advanced cancers, the others being screen detected. From the values of the rate of advanced clinical cancers in the first year and in the second year of the interval between two screening rounds, it is possible to evaluate the number of advanced clinical cancers that are missing, or, in other words, cancers that have been intercepted by screening. More than 60% of advanced clinical cancers are intercepted by screening. These missing advanced clinical cancers were detected earlier by screening with a lead time that can be estimated to more than 1 year. 60% of clinical advanced cancers are thus replaced either by early stage cancers or by advanced cancers diagnosed and treated earlier. 1 month delay in surgery results in a 10% increase in overall mortality. With surgery performed 1 year earlier due to mammography, one should see a strong decrease in breast cancer mortality. Now we will see that mammography screening programs have had almost no effect on breast cancer mortality in the long term. In Sweden, Peter Goche and colleagues found almost no effect of screening mammography on breast cancer mortality. In the USA, Gilbert Welsh and Archie Blair found a disproportionately small decrease in breast cancer mortality and a large increase in breast cancer incidence associated with screening mammography. They attributed the relative lack of mortality decrease relative to the incidence increase to overdiagnosis. Similar conclusions regarding overdiagnosis were reached by Carsten Jorgensen in Denmark, Per Henrik Zahl in Norway, and Philippe Autier in the Netherlands. As a consequence of these findings, Switzerland decided to discontinue its national screening program. In this study, Welsh found that in the USA, mammography screening has not decreased the incidence of metastatic breast cancer. This finding is consistent with the fact that mortality from breast cancer usually occurs from metastasis. In conclusion, mammography screening is strongly beneficial for women whose cancer is detected by screening. Mammography screening should result in a strong decrease in breast cancer mortality, which is not observed because incidence of breast cancer increases during screening. The fact that breast cancer incidence rates are always increased after mammography screening implementation indicates that this is not a coincidence and that the increase is related to screening. The fact that this increase in breast cancer incidence translates into mortality, which cancels the benefits of screening, indicates that this is not overdiagnosis. In the next slideshow, we will see how we can visualize the epidemic of mammography-induced cancers.